Assalamualaikum warahmatullahi ta'ala wabarakatuh and a pleasant day to each and everyone. We are the Group 2 and welcome to our video report. We'll be discussing about the Comprehensive Emergency Obstetrics and Newborn Care or CEmONC. So here's the content outline of our report. So meet the Group 2 members. So moving on to the introduction of our topic. So first, let us know what is the Comprehensive Emergency Obstetric and Newborn Care Services, or more commonly known as CEmONC. So CEmONC are the interventions provided to pregnant women and newborns experiencing fatal complications including severe bleeding, infection, prolonged or obstructed labor, eclampsia, and asphyxia in the newborn. So according to the analysis of the maternal and infant mortality data revealed that 75% of maternal deaths occurred during the intrapartum and postpartum, which intrapartum means the time period of spanning childbirth from the onset of labor through delivery of the placenta, and postpartum means the period begins immediately after childbirth as the mother's body, including hormones levels and uterus size, return to a non-pregnant state, and 25% occurred in antepartum, which this means before childbirth. So, bakit nga ba namamatay ang mga bata or the mother during this period? So, the most common issue was the referral, and this can also be the most common cause of death. So the referral is when the hospital where the pregnant woman accessed for care but did not have adequate facilities, she had to be referred to another hospital somewhere. So if the hospital na pinuntahan ng mother na nasa critical stage is di kaya i-handle or i-address ng first na hospital na pinuntahan niya ang kondisyon ng patient or pregnant mother, they have to refer that patient or that pregnant mother to other hospital na kaya i-handle o i-treat ang patient. However, covering the distance between two hospitals at such a critical stage could prove fatal, as it was usually the complicated cases that were referred to other hospitals, especially in the rural areas. So hence, it was decided to strengthen the obstetric and newborn services in the hospital, which led to the creation of the Comprehensive Emergency Obstetric and Neonatal Care Centers. So a government order was passed to establish the Comprehensive Emergency Obstetric and Newborn Care Services, or more commonly known as CEmONC, to provide medical emergencies for the pregnant woman and to save the baby and the mother.
I am Ditongcopun Reham M, and I'm going to report the salient features of Comprehensive Emergency Obstetric and Newborn Care. So the center is equipped with both the manpower and the infrastructure required to care for the mother and the newborn. The center has obstetricians, pediatricians, doctors, staff nurses, lab technicians, and support staff on duty, and anesthetists on call. So these provider facilities shall also provide comprehensive emergency postnatal care such as low birth weight newborns, premature newborns, and sick newborns. In terms of training and physical infrastructure, intensive inputs were provided to ensure quality care. Around 508 doctors and 562 nurses positions have been sanctioned and posted exclusively for these services in addition to the existing doctors and nurses. So the center is equipped with a fully functional maternity block, including a labor ward, operation theater, blood bank or storage unit, newborn ward, newborn intensive care unit or NICU, and isolation ward.
Good day everyone, I am Laca Norjana M and I'm going to discuss about how CEmONC centers established. In September 2004, a government order was passed to establish CEmONC centers in the state, or Comprehensive Emergency Obstetric and Newborn Care Services, or more commonly known as CEmONC, is the interventions provided to pregnant women and newborns experiencing fatal complications including severe bleeding, infection, prolonged or obstructed labor, eclampsia, and asphyxia in the newborn. During this establishment, there are three phases that was created. During phase 1, we have 66 centers were established, which is 52 projects in hospitals that are run by the state or local governments such as dispensaries, peripheral or public health centers, rural hospital, and district hospitals. And 14 is also a tertiary care centers. When you say tertiary care centers or tertiary level hospital, is a highly specialized staff and technical equipment like for example, cardiology, intensive care unit, and specialized imaging. While in phase 2 and 3, in phase 2 there are 32 centers were established, and in phase 3 there are 27 centers were established. They will help to perform emergency obstetric functions as in BIMONC provider facilities, as well as it provides surgical delivery or cesarean section and blood bank transfusion services and other highly specialized obstetric intervention.
Assalamualaikum warahmatullahi ta'ala wabarakatuh, and good day to each and everyone. I am Datu, Noor Panutulan, member of Group 2, and my part here is to discuss about the services available in a comprehensive emergency obstetrics and newborn care. First, we have resuscitation of all obstetric emergencies. We have here a sample of the obstetric emergencies. First, we have the eclampsia. So it is actually the new onset of seizure or coma in pregnant women with pre-eclampsia, which is characterized by high blood pressure occurring in pregnancy and rarely postpartum. Next, we have the shoulder dystocia, which is also an obstetric emergency associated with failure of the shoulders to deliver spontaneously. Next, we have the amniotic fluid embolism. This is also an obstetric emergency which needs resuscitation. So next is the resuscitation of all newborn emergencies. So, newborn resuscitation refers to emergency medical intervention techniques employed immediately after childbirth to assist babies who are not able to breathe independently after birth. So we have the types of newborn resuscitation. First is the ventilation. Next, we have the suctioning and the heart massage, which is a cardiac massage. We have basic newborn resuscitation. Next service is the blood transfusion facilities with all groups of blood. So, blood transfusion is a procedure that restores blood to the body. We also have the different types of blood transfusion. Note that before a blood transfusion, a healthcare professional will remove the white blood cells from the blood because it can carry viruses. Next service, we have the supportive lab and imaging. So this basically refers to laboratory tests and imaging tests. We also have the PPTCT services. PPTCT stands for Prevention of Parent-to-Child Transmission. This involves counseling and testing of pregnant women, detection of HIV-positive pregnant women, and the administration of prophylactic nevirapine to these women and their infants. Next service, we have the free antenatal and postnatal counseling services. So, antenatal refers to the period before birth. On the other hand, postnatal refers to the period of the first 6 weeks after birth. Next service, we have the free 108 emergency ambulance system. So it is an emergency response service providing integrated medical, police, and fire emergency services. We also have the uninterrupted power supply and healthcare waste management facility.
Good day, I am Arafat S, Hadji, Noor, and now I will be presenting about services in the labor room. We all know that labor room is one of the most versatile rooms in a hospital and birth centers. It is called a labor, delivery, and recovery room, or LDR. This is the type of room that some hospital and almost all birth centers use for their care. Once you are placed in a room or in the labor room, this is the room that you will use for your labor and birth, including the initial hours of recovery. So first is the emergency met by trained obstetrician and staff nurse round the clock. There are trained obstetrician and staff nurse that are on standby round the clock in labor room when there is an emergency to provide support and care. Next is emergency treatment protocols. Equipment and drugs are available in the casualty, labor room, and newborn care services. Emergency treatment protocols, equipment, and drugs are important and essential to successfully manage emergency patients that needed to be available all the time in casualty and most importantly in labor room and newborn care services. Next is emergency USG or ultrasound are taken for maternal emergencies. Emergency ultrasound refers to an examination performed at the bedside by an emergency physician or obstetrician. This examination has limited goals that allow the obstetrician to make rapid decisions, identify life-threatening diagnosis, and expedite the operative management of emergency patients. Next is partograph are used. The partograph, sometimes known as partogram, is usually a pre-printed paper form on which labor observations are recorded. The aim of the partograph is to provide a pictorial overview of labor and to alert midwives and obstetricians to deviation in maternal or fetal well-being and labor progress. And lastly, biomedical waste management procedures followed. Biomedical waste disposal is particularly important for safety and effectively when it comes to medical supplies and environment in labor room because some waste can be contaminated with diseases or dangerous pathogens. So next is services for care of the newborn. We all know that all newborns require essential newborn care to minimize the risk of illness and maximize their growth and development. So first is resuscitation of a newborn by trained pediatrician. Trained pediatricians are responsible for providing newborn resuscitation, which is a series of emergency procedures performed by trained pediatricians to support newborn babies who are not breathing, are gasping, or have a weak heartbeat at birth. Some basic resuscitations that they perform are bag mask, ventilation, and oxygenation. So next is emergency treatment protocols. Equipment and drugs are available in casualty, labor room, and newborn care. As what I've said, emergency protocols, equipment, and drugs are important to successfully manage emergency patients that needed to be available all the time in newborn care services. And lastly, the initiation of breastfeeding immediately after birth. It is recommended in a newborn care services that breastfeeding should be initiated early and preferably within 1 hour of birth. Breastfeeding within the first hour allows the infant or newborn to receive the benefits of the mother's colostrum.
Good afternoon. I am Nahari P sa Hadji Ibrahim. The assigned topic I will be discussing is about designate the CEmONC capable facility or network of facilities. A CEmONC capable facility must have the following characteristic. A. Capable of managing maternal emergencies, including cesarean sections, as well as handling basic and emergency newborn care and providing blood transfusion and storage services. Letter B has a set of sophisticated equipment, special infrastructure, and highly skilled health staff to deliver said services. The letter C is strategically located to ensure wide accessibility to clients, substantial caseloads to maintain skills, proficiency, and adequate financing for operational viability. And the last one has the responsibility to serve its target population, provide quality care, and reduce financing barriers to access. Follow these steps in designating the CEmONC capable facility in order to update the designation of facilities in the PIPH or facility rationalization or facility mapping. Number 1, identify and list all hospitals, both private and public, located near target population within and outside the jurisdiction of the LGU. The list shall include the following information. This table can be used in the assessment. This is an example of short list of CEmONC capable facilities. Number 2, based on the list of facilities, come up with a short list of hospitals to be designated as CEmONC provider by applying the following criteria. The first one is select only licensed facilities. Select those with level 2 PhilHealth accreditation. The third one, determine which of these licensed hospitals are within 1 hour travel time from the rest of the targeted population using most common mode transportation, especially the mode of transportation. Next is rank hospital which are within 2 hours from the resident of the identified priority population group. And identify which of these are accessed by the client the most.
Assalamualaikum warahmatullahi wabarakatuh and good day. I am Hadji of Nishren Layra from the group 2 and I will be continuing the discussion about the comprehensive emergency obstetrics and newborn care or CEmONC. Designate the CEmONC capable facility or network of facilities. So for the number 3, assess if the hospitals in the short list meet the CEmONC capable facility can provide. So the management team can use the table 5 below as guide. Will serve as the checklist. So does the facility have adequate staff requirement of a CEmONC facility? Indicate deficiency under remarks column. So yes, or these are the remarks. If yes or no, then you will have to just check if it is yes or no. For the number 4, designate the most capable facility as the CEmONC capable facility. So based on the results of the capacity assessment for core services, designate the hospital most capable in providing CEmONC services, which is within 1 hour of travel, accessible to most of the priority population and preferably government-owned facilities. So if there is no CEmONC capable or network of facilities located within 1 hour of travel time of the priority population, designate the next closest CEmONC capable or network of facilities to the area which is within 1 to 2 hours travel time. So efforts though must be exerted to ensure that only skilled birth attendants or skilled health professionals manage all births and that emergency transport and communication services are available to facilitate referral. If only private facilities can be designated as providers, the LGU would have to enter into a memorandum of agreement with the facility. There is also a possibility that the nearest and most appropriate CEmONC capable facility is in another LGU or a DOH retained hospital. So the LGU would have to enter into an agreement similar to that of the private sector. There is also a possibility that the facility may lack a doctor who can perform cesarean operations. The LGU can also negotiate with the private practitioner to provide CEmONC services to their clients as needed. So this is very important to the mother who are giving birth and has a complications on giving birth. So they need a cesarean or a healthcare provider or healthcare professional who can perform cesarean operations or to be specific, a surgeon. So, aside from that, this can also as someone who can also provide an newborn care to the newborn babies.
So as you can see on the screen, this is the Table 8 Service Delivery Gaps Proposed Interventions for CEmONC Capable Facility or Network of Facilities. Now let us move on to the interventions. First, after assessing gaps in terms of adequacy and capacity of personnel, functional equipment and infrastructure, and adequacy of logistics and supplies, identify appropriate interventions to address these gaps and fill up column 2 of the Table 8. Next, determine the target time frame for the start and completion of proposed interventions in column 3 of Table 8. Next, identify the resources needed for proposed interventions in column 4, including the number of resources needed in column 5, unit cost in column 6, and total financial requirements in column 7. Next, consult and negotiate the terms of use of the CEmONC facility with the head of the designated CEmONC hospital and agree on the following. First, propose an arrangement for service use to govern the terms of accessing the CEmONC services. This may include the definition of a special service package for the target population, provision for subsidized or discounted user fees, compliance to minimum quality of care levels, referral arrangements, and in the social marketing and promotion of the facility as the designated CEmONC. Second, negotiate the terms of service used with the head of the CEmONC facility and formalize these agreements and arrangements through an executive order if it is owned by LGU within the province or a memorandum of agreement if it is a private or owned by adjacent LGU. And third, use these agreements and arrangements as basis for estimating investments and in the allocation of resources, and compliance to the terms of service use will form part of these formal agreements as basis for mobilizing resources by the province and component LGUs or independent cities in support of the CEmONC. So that's all. Thank you.
So as for my part, the highest level of care in the MNCHN core package of services should be available to priority population groups and the public in general. Follow these steps in assessing gaps of CEmONC capable facilities. So the first one is assess adequacy of staff using the following human resource standards. A typical CEmONC capable facility should have the following human resource complement: 3 CEmONC teams composed of 1 doctor, preferably obstetrics, gynecologist specialist, or surgeon or GP trained in CEMONC, one anesthesiologist or GP trained in anesthesiology, one pediatrician, three operating room nurse and maternity ward nurse, three medical technologists, itinerant team composed of one doctor and two nurses. So the second one is assess competency of health personnel of the CEMONC. So the third one is assess suitability of equipment and infrastructure for CEMONC. The fourth one is assess adequacy of logistics and supplies. So the fifth one is using the table 8, fill up the gaps that were identified in terms of adequacy of staff, competencies not met, equipment needed, infrastructure that need to be improved or developed, needed logistics and supplies under column 1. And this is our references to our report, and that's all for our video. Thank you for watching.